Thank you everyone for joining us. We're just going to take a few more minutes to let people log on and get ready, and then we'll get started.
And while everyone's coming in, if you want to let us know how you heard about Socialist Night School, I'd very much appreciate it. Got the poll coming up and on your screen now.
We'll give people 2 more minutes to log on and then we'll start. Okay, why don't we get started? All right, thank you everyone for coming. My name is David Kaib. I'm one of the organizers of the night school. He, him. Metro DC DSA Socialist Night School is a series of sessions that explore basic ideas, concepts, historical socialism. This is our 5th semester, and so far we've done what is socialism, and tonight we're having our 3rd class. We're very excited for it, the healthcare fallout. At the end of the session, we're going to announce some additional ways you can this issue and then other things related to the chapter. If you're interested in more tonight, you can check us out on the chapter Slack at night-school or on Twitter at nightschool_D. You can also check us out at, or you can email us at politicaleducation@mdcdsa.org. Is organized along with our friends in the Medicare for All working group, and they're going to lead us through here. Turn it over to them.
Thanks, Dave. Hi, my name is David Winston. I'm one of the co-chairs of the Medicare for All working group. I want to thank Socialist Night School for helping us set up our first ever event with them. And I want to thank all of our distinguished panelists for being here today. I think this is the essential time to be talking about how to fight for single payer, how this pandemic has exacerbated our healthcare system, and what we can do about it. So with that, I'll bring it over to my co-host or co-chair, Gayatri.
Hey everyone, my name is Gayatri, and I'm also a co-chair for the Medicare for All working group. And this is really our first event, our first major event as a working group. And I just wanted to say thank you to the panelists and thank you all for tuning in this evening. I think we're going to have a very, very good discussion about what's been happening in our country for the past, many years as we've been fighting for Medicare for All, but also currently in light of the pandemic and historic unemployment, on how exactly we need to rebuild from this crisis. So I just wanted to give a short intro on why we wanted to do this event. And as there's so many different types of fallouts that are happening, it's really easy to lose track of the fact that so many people still lack access to healthcare. And as people lose their jobs, they are also losing access to their health insurance. And the panelists that we've gathered today are leaders in the field that have been fighting for Medicare for All in their respective backgrounds for an entire lifetime of experience. And we're very happy to have them with us today. And I'm not going to take up much more time in this intro because I'd really like to transition over to hearing from each of them about their background and experiences with Medicare for All, and learning how we can work together in the next generation of this fight.
And with that, I'll announce our panelists for this evening. We have Amira Sequeira, the lead legislative advocate for National Nurses United, Melinda St. Louis, the director for Medicare for All for Public Citizen, Mark Dudzik, the national coordinator for the Labor Campaign for Single Payer, and Robert B. Friedland, the director for Healthcare Management and Policy Program, Georgetown University, as well as the chief economist for Maryland Medicaid. So we'll be starting with Amira Sequeira. Amira is the lead legislative advocate for National Nurses United, the largest union of registered nurses in the United States. She leads federal legislative advocacy work for the union on Capitol Hill, working to win Medicare for All, workplace protections for registered nurses, and other health, environmental, and economic policy priorities that would benefit nurses, patients, and working people. Amira is a longtime healthcare justice activist and spent more than a decade working in the global AIDS movement. She previously served as Associate Director for International Campaigns and Communications for the Health Global Access Project and as the National Coordinator for the Student Global AIDS Campaign. Amira holds a master's degree in the history of science, medicine, and technology from the University of Cambridge, where she was a Gates Scholar, and a Bachelor of Arts from Columbia University, majoring in history of public health and in sustainable development. And with that, I'll give the floor to Amira.
Hi, thanks so much, David and Gayatri. It's great to be here with you guys today. I live in the Metro DC area and was really excited to be asked to take part in this. So as David said, I work for National Nurses United, which is the largest union of registered nurses in the United States. And as many of you likely know, nurses across the country have been fighting for Medicare for All for decades. We've been fighting for guaranteed healthcare for patients for decades, and nurses have been in leadership of this fight for so long because registered nurses have been on the front lines. They are on the front lines at the bedside in our hospitals every day. And so they have been watching as our healthcare system has become more and more focused on profit, and less focused on providing quality patient care to everyone who needs it over the past few decades. So I want to talk to you a little bit about what has been happening on the front lines of this pandemic, and draw some connections between the state of our for-profit healthcare system and our country's absolute inability, complete failure to address this pandemic. So for 9 months now, 10 months now, nurses across this country and healthcare workers across this country have been caring for patients during this pandemic, as COVID-19 infection rates have continued to surge over and over and over again in parts of this country. And our healthcare workers have been doing this work consistently without the personal protective equipment that they need to do their jobs safely. And they've been watching as our healthcare system and our public health system has failed to implement the infection control measures that we should be implementing in order to reduce the spread of COVID-19. So I'm going to talk specifically about what's been happening in hospitals and use the failure to get protective equipment to healthcare workers as a lens into our for-profit healthcare system, because I think it's a really useful one to understand this fragmented healthcare system we're living in. So you all have probably seen time and time again, month after month since March, nurses and doctors and healthcare workers in the media telling their stories about how they are risking their lives every day to care for patients with COVID-19 without PPE. This is just a baseline infection control measure. Make sure that frontline workers who are likely to be exposed to COVID-19 have PPE so that they are not exposed and so they do not contract the virus. We have failed. We are 10 months into this, and we have not increased our production of PPE the way that we need to. We do not have standards to protect workers on the front lines, including healthcare workers. We have abjectly failed. So there are three main reasons why nurses have not been given the PPE that they need. The first is that at times, many times across the country, hospitals that have had stock of personal protective equipment have refused to give it to nurses. They've refused to give it to them because they're worried about having a shortage at a later date, and they don't want to purchase additional supplies because they don't want to spend money on buying more PPE. So that's one reason. The second reason is because federal and state government efforts to distribute PPE from stockpiles have been completely ineffective. So time and time again, we have heard that the federal government is releasing N95 respirators from a federal stockpile, or a state government has purchased a number of N95s or PAPRs or other PPE. PAPRs are an increased, a more protective form of a respirator than an N95. And we haven't seen them. Nurses just haven't seen them. We don't know where they've gone. The third reason is that there has been insufficient production and purchasing of personal protective equipment at the levels we need to protect healthcare workers during a pandemic. So the thing is that this didn't need to happen, right? Our hospitals should be prepared with stockpiles of protective equipment that has not expired, and the system as a whole, we should have a healthcare system that as a whole has a strong medical supply chain coordination mechanism. However, what has happened as the profit motive in healthcare has become more and more a forefront of our healthcare system in the past 30 to 40 years is that our hospitals are now operating in what we call a just-in-time model, in which they only purchase necessary equipment when it's needed because they want to reduce their expenses, because hospitals are often for-profit ventures, or they're not for-profit ventures, but they act just like they're for-profit ventures, right? So they are focused on reducing their expenses to increase their profit margins. If we were in a single payer system, this would look totally different, because hospitals would no longer, profit would no longer be an incentive in our healthcare system. So under the Medicare for All Act, under the House bill, the Medicare for All Act of 2019, and in Congress, that bill would establish global budgets to finance hospitals. And so hospitals would literally be given a lump sum that would be negotiated with the Medicare program. And part of that budget would be dedicated to ensuring that hospitals can purchase adequate supplies of PPE to prepare for infectious disease outbreaks. The new system, under a Medicare for All system, we would be able to guard against the raft of closures of safety net hospitals, hospitals in rural areas, in underserved areas, in urban areas that we're seeing now. So in our for-profit system, we have this unbelievable lack of transparency, and the entire system is fractured. So any efforts to distribute PPE have been hindered by the fact that we don't have a coherent system by which, on a national level or a state level, we can track where where, which hospitals have what PPE and where it's needed most. I'm just talking about PPE, but this would apply to testing, testing equipment, to other critical medical supplies. Yeah, the part of the reason we've been unable to scale up our testing infrastructure in the United States is because of this fractured system. So in Canada, for example, Canada has had a much higher success rate of increasing their testing capacity because of having a single payer system administered at the provincial level, right? It's much easier to implement a program like that. So a Medicare for All system, one of the things about it at its core, just connecting it to this PPE issue, is that we would be able to track, we would have increased transparency to track things like PPE availability in stock, testing equipment, and a testing program. We would have increased reporting mechanisms, and we would be able to ensure a more efficient and effective distribution mechanism for necessary medical supplies in the midst of a pandemic. So in a pandemic like this, you need to be able to have a coordinated healthcare response. You cannot have a coordinated healthcare response when you do not have a healthcare system. I grew up in Canada, and so I know what it's like to live in a single payer system. And what I often say is, in the United States, we don't have a healthcare system. We have a mixed up array of for-profit health insurers, for-profit health hospitals, and none of it works together to ensure any sort of coordinated healthcare response. And so as long as we are in a system like this, it is going to make it very difficult to respond to a pandemic. So I don't want to take too long. I will pause this here, knowing that my colleagues on this panel are going to address other really important issues, including, what it means when people don't have insurance in a pandemic, what it means when people are losing their employer-sponsored insurance in a pandemic, what this pandemic has shown us, has highlighted in terms of the racial disparities in our healthcare system. All of these things are things that nurses are experiencing on the front lines. So I'll pause it there and look forward to answering questions and talking more after.
Thank you so much, Amira. That was lovely. I wanted to just move on to Melinda St. Louis next to give her short introduction to her background and what she's been working on. Melinda St. Louis is the director for the Medicare for All campaign at Public Citizen. She is, for the past 20 years, Melinda has led multiple campaigns that challenge corporate power and promote economic justice and human rights, including fighting big pharma, greed in global trade, greed in global trade agreements. She is now thrilled to focus her energy on building a movement to finally deliver guaranteed healthcare for everyone in the United States. She received her master's degree in public policy from Georgetown University. So Melinda, you're up next.
Thank you. Thanks. And again, it's really a pleasure to both share the panel with my dear colleagues, as well as to be here with all of you tonight. So Public Citizen, for the past 50 years, nearly 50 years, is an organization that has been challenging the role of unchecked corporate money and power in our democracy. And we have worked to push our institutions through litigation, through lobbying, through grassroots organizing to promote the public interest as opposed to just the corporate interest. And we focus on a range of public policy issues from product and food safety to financial, environmental regulation and labor protections. And really nowhere has the outsized influence of corporate money created a more insane policy framework than in healthcare. The United States has a uniquely inefficient, very expensive, and completely inhumane healthcare system among every peer country that we have in the world. 1/3 of our healthcare dollars does not go to healthcare. So we spend double per person on what our peer countries spend on healthcare, and we have had far worse health outcomes. This is all prior to COVID. And in fact, we actually even spend more in public money, so more in what we collect in taxpayer money on healthcare per person than other countries that cover every single person in their country. Now, how could that possibly be? And that is because we have invested in a fragmented, profit-driven system that that Amira mentioned has been completely unable to deal with the COVID pandemic. We have, before COVID, there were an estimated 30,000 Americans dying each year because they lacked healthcare coverage. It was nearly 100 preventable deaths a day, again, before COVID. Nearly half of adults were reporting not going to the doctor when they were ill or injured due to cost before COVID. Skipping, 1 in 3 adults skipping medical treatment that they needed. 1 in 5 cutting pills in half or skipping their prescriptions before COVID. And that's largely why we ranked before COVID 43rd among the world's nations in life expectancy. That's behind Cuba, Costa Rica, and Chile, and many other countries. And so now enter the pandemic. And what we've seen is that COVID has further exposed just how broken and, importantly, inequitable our current healthcare system is. And it meant that we were in a uniquely bad position to be able to confront the pandemic among other countries. Obviously, a huge failure of leadership on all levels in terms of how we address the pandemic, but our healthcare system put us at an extreme disadvantage. The financial barriers to care that people have had over the years, it made them less likely to seek testing and treatment. It required an act of Congress to try to force private insurers and to force hospitals to allow for free testing. We know that meant that testing was rolled out much more slowly. We know still, in order to get a rapid test, you often have to pay sometimes hundreds of dollars for tests, and treatment never was agreed to be covered in COVID, and we had this piecemeal way of some private insurance making promises that they were going to waive cost sharing for COVID treatment, but only for people in certain plans, not the employer self-insured plans, and nobody could really sort through it. And it was all voluntary. They had premature expiration dates to these promises of free COVID care, and only after organizations like ours publicly shamed them would they move the deadlines past April, past May, past June. And so all of this effort going in to simply provide people with the most basic testing and treatment for COVID is just an outrage, and it has put us at a huge disadvantage. And that has meant extreme inequities in terms of how COVID has affected different populations. We know that our for-profit system has created enormous racial disparities, resulting from institutional racism. Communities of color have been disproportionately among the uninsured in our country. Hospitals that serve communities of color have received less funding because funding of hospitals is based on the ability of private insurers to pay high rates. And so we've seen those hospitals suffering. And so that's meant that there were higher numbers of comorbidity rates among these populations, which meant that the disease was much more deadly. Here in DC, the average life expectancy in Ward 8, where 90% of the residents are Black, is 16 years lower than the average life expectancy in Ward 3, where only 5% of the residents are Black. That means they would live 16 years longer on average than a resident in Ward 8. And the mortality rate for Black infants in the district is 4 times higher than that for white infants. And Black residents are more than 6 times more likely to die from diabetes than their white counterparts. And those were estimates before COVID. And we know that COVID then has disproportionately harmed Black residents, despite making up 45% of the population. Black DC residents made up 74% of reported COVID deaths. So this is a result of a system that privileges private insurance, privileges people who have the ability to get insurance through their employer, and obviously with just absolutely deadly consequences, not just for those populations, but for everyone, because we haven't been able to control this deadly pandemic. And I just want to just mention the other piece from public citizens' perspective has just shown that what the pandemic has shown is that the profit motive in our healthcare system is just completely a perverted incentive for how a healthcare system is supposed to work. Even though I've been doing this work for years, I was still shocked to see that private insurers were making their biggest profits in history during this pandemic. That at the time, they are paying for the least amount of care. So United Healthcare posted $6.6 billion in profits in one quarter. It was the highest in its entire history. At the same time, when hospitals were laying off doctors and nurses because all non-COVID care had been pretty much stopped. And so we see a pandemic where we need healthcare workers, they're being strapped, they're not getting PPE, they're getting laid off or working extreme overtime, and the insurers are making record profits. Hospitals, as I mentioned, they were already in a precarious position, especially the safety net hospitals. And so we've seen further consolidation among hospitals, private equity companies, both of hospital systems and then also contracting certain provider types, taking them out of network and then charging extreme surprise bills to people. We've seen, there have been media reports of people receiving surprise bills of $20,000, $30,000 for their COVID care when it's supposed to be free. And then finally, Big Pharma instantly saw COVID-19 as a jackpot. Many have tried to exploit the crisis. Obviously, we're hearing these great news of promising vaccines. That's great news. But those vaccines have benefited from immense public money investments. The NIH, the main proteins the spike proteins that everyone's talking about, that was all public research that we have funded. And these private pharma companies would like to exploit that, hoard the knowledge, and not actually be able to produce the vaccines to scale and to make billions of dollars. And that is just what, in a nutshell, what has been wrong and why a third of our healthcare dollars goes to profit, goes to CEO pay, and does not go to care. So that's why we've been, really teaming up and excited to team up with our partners. And the good news with the American people are overwhelmingly supportive of a different healthcare system, of a Medicare for all system. And we've been working, and I'd love to talk more with folks in the Q&A about some of the organizing we've been doing to support Medicare for all legislation. And we've been really working a coalition effort to pass municipal resolutions all over the country in support of Medicare for all. And there's, in fact, an effort underway here to try to pass a resolution through the DC City Council. So I would love to talk to folks about that. We have a website, medicareforallresolutions.org, and folks can sign up to be part of that local organizing as well. So I'll leave it there.
Well, Melinda, thank you so much for speaking and presenting us at first such a dire situation, but also some optimism that there's something we can do about it. So I think that is a good theme of the night. And with that, we'll move on to our next speaker, Mark Dudzik. So Mark is the national coordinator for the Labor Campaign for Single Payer, based in Washington, DC, and has been a labor activist for over 40 years. In 1979, he joined Rahway, New Jersey, Local 149 of the Oil, Chemical, and Atomic Workers, now part of United Steelworkers, after helping to organize his precious metals refinery. He served as full-time president for his local union and as president for the largest district council of the OCAW. After the death of his friend and union brother, Tony Mazzocchi, he came to Washington, D.C. in 2003 to work on Tony's many unfinished projects, including efforts to build a labor-based political party, advance occupational safety, promote working class culture, and win national health care. The Labor Campaign for Single Payer was founded in 2009 to ensure that the voice of grassroots labor movements is heard in the debates over the future of healthcare and to advocate for a single payer Medicare for all system. And with that, I'll give the floor to Mark.
Well, thanks so much. It's great to be here, to listen to my colleagues talk about this unique moment in history. So when we organized the labor campaign for single payer, we came together around three basic ideas. Number one, healthcare is a fundamental human right. It can't be linked to employment. It must be treated as a public good, not as a market commodity. We have to run healthcare the way we run other public goods like education and libraries and highways and Medicare for those over 65. Secondly, our understanding of the task ahead of us is that we are beyond the need for more debate over wonky policy proposals. Almost the entire industrialized world has solved the problem of how to make healthcare a birthright for everybody in their country. So this is not rocket science. What we need is a strategy to confront the concentrated economic and political power of the medical industrial complex that stands between the American people and their healthcare. And thirdly, to build that power, labor has got to be central to this fight. We have got to move the institutional labor movement into this fight. Labor at its best exists to fight concentrated economic and political power. And we cannot win this fight without substantive participation of the institutional labor movement in this fight. So you've heard from my colleagues, and you've all lived through the last 7 months, and we are, experiencing the tragic consequences of what happens when you link healthcare, access to healthcare, to employment, like more than half of all Americans do right now. We're living through a COVID depression, which is nowhere near concluding, and will likely outlast the scourge of COVID in this society. Since March, 1 million workers a week have lost their jobs. 1 million workers per week have lost their jobs. And with that, their healthcare has become massively insecure. Sometimes they've lost it immediately. Sometimes it's held on for a month or two, but they've lost any aspect of healthcare security as a result of this. This has affected the most vulnerable workers. Something like 90% of hospitality industry workers are out of work. These are low-wage workers who, through a couple of decades of tough union struggles, have finally scrabbled their way into a ability to do basic survival and have basic security around things like healthcare. And many of the frontline workers still working because of the way that work is characterized in this country, and the ability to organize are not covered under employment-based healthcare provisions. So, the people who deliver your food and your groceries are most likely considered some kind of gig or independent worker and not eligible even for bargaining rights, and have no access to health care. And many of the other workers who are out there trying to survive in the midst of this COVID depression have no access to health care. So this crazy system that we live under, which was sort of an accident of history, and was never a good idea. It's always been a major driver of inequality in this society. You heard Melinda talk about healthcare disparities. When you have a labor market that's segmented by race and gender, and access to healthcare depends on your position in the labor market, it just replicates and reifies all of those disparities that are built into the labor market. When healthcare is treated as a commodity and is available, the more money you have, the more healthcare you can purchase. That you drive the sort of inequality in access to health as a result of the way we treat it. Healthcare Linkage to employment has also driven wage stagnation for the last quarter century. Working class wages in this country have basically stagnated, and every worker trades wages for health care. And every bargaining between workers and employers, healthcare is used as a threat that hangs over workers' conditions of employment and their ability to secure wage increases and other improvements in their job. So we have got to break free. We've got to take healthcare off the bargaining table and make it a right for everybody in this society. Just a couple of words about the Biden administration and our view towards that, as we're looking for what is hopefully going to be a peaceful transition of power. And I'm knocking on wood as I say that, but we, like almost everybody in the labor and progressive movements, we are ecstatic that the Trump administration is coming to an end, and its vicious, incompetent, racist, fascist propensities will be driven from power. But nonetheless, we have to be pretty open about what to expect under a Biden administration. And while hope may spring eternal, we have to realize that Biden is no FDR and no LBJ. Biden has been a founding member of the neoliberal wing of the Democratic establishment. He served in the Senate since 1972. On healthcare, he has never, since 1972, never supported any kind of national healthcare legislation, including bills that had huge support initiated by Ted Kennedy in the 1970s and Paul Wellstone in the 1990s. So, we have to know what to expect. And, everybody can surprise you sometimes, but my sense, in the sense of the labor campaign, is that the path forward to healthcare justice is not going to be with the Biden administration, but in conflict with the Biden administration. And we've got to begin to think strategically about what that means. We also think that the facts on the ground will continue to drive the political agenda, regardless of what the Biden administration tries to do about that. That's just a reality. The healthcare system is in major meltdown. It's unsustainable. It's in crisis. Vast supermajorities of the American people are demanding change. The labor movement is slowly moving to an understanding that change is essential for it to adequately represent their members. And we think that that's going to drive the agenda, regardless of what the administration and their supporters want to do about it. And the labor has made some significant advances. Last year, for the first time since the early 1990s, unions that represent a majority of organized workers in this country endorsed the Medicare for All Act introduced by Representative Jayapal in the Congress. That was a huge breakthrough. The work of a lot of us on this call and elsewhere helped to make that happen. And this month, the AFL-CIO submitted its recommendations on healthcare to the Biden administration's transition people. And the top recommendation for the first time, at least in this century, and I don't know when the last time the AFL made this recommendation to an incoming president, the top recommendation was to move towards a single payer Medicare for all system. So we have moved substantially from where we were a decade ago when we launched the labor campaign. But there has been considerable backpedaling that's also taken place within the labor movement. And it has to do most centrally with the reluctance on the part of many national labor organizations to undermine and disrupt the sort of instrumental political relationships that they've built up in order to advance other issues and concerns of their unions. And that's really sort of the central problem that we have to address. And, if I'd be glad to talk about that a little further in the Q&A section as we move forward. Thank you.
Thank you so much, Mark. I'm going to jump next to Dr. Friedland. Dr. Friedland is the director of the Healthcare Management and Policy Program at Georgetown University. He's also an associate professor within the university as well, and teaches a variety of courses in healthcare economics, statistics, and policy analysis. Dr. Friedland has had a range of employment experiences in single-payer health reform, including as the former chief economist for Maryland's Medicaid program.
Thank you. I'm delighted to be here. Can you hear me okay? So I'm glad, I appreciate being a part of the panel and being at the end of the panel to hear your comments. I'm very appreciative of your efforts to push forward the concept and perhaps the specific legislation of Medicare for All. As you know, the push for some version of national health insurance has been around for a long time. And it's remarkable to me how difficult it was to even get the Affordable Care Act passed, and with such rancor, after such a long period of time of pushing, and despite inequality growing over the last 30 years, and despite the fact that all the fissures that you see, unfortunately, so vivid in this pandemic, were all there. All the fissures were there, and certainly the issues about efficiency and equity with respect to healthcare have always been obvious, and yet we have such a hard time having a conversation about it. And the fact of the matter is, the deck is stacked. People are so afraid of change that even the ACA, as trivial as you may think it is in terms of trying to put your arms around a system and improve the system, even the very notion, which I agree with completely, that this is a fundamental human right is an arguable point. People just don't understand or believe it or accept it. And so the fear of change has been so dramatic, it's disheartening. It's disheartening. So I agree with almost everything my previous speakers have said in terms of diagnosing the problem and articulating the inefficiencies and inequities. We have in this country some of the best healthcare in the world next to some of the mediocre healthcare in the world. And it's really sad and inequitable. So I can't advise you on how to push a political strategy, other than to say, I commend you for trying and for continuing to do it. It has changed the dialogue, but the dialogue that I've been watching up close for over 40 years, has moved, but not as much as I suggest in the last 10 years. I hope that this period, I really pray this period can result in a new deal, so to speak, with respect to a lot of aspects, industrial targeting to deal with the parts of society that doesn't even believe that COVID's real. Dealing with opportunity zones where people are disenfranchised and disheartened and don't believe government can do anything good. We really have to see a reform, and I certainly pray that the next administration will be able to do it. I did notice a headline that GSA is acknowledging that there's a likely winner and the money is going to be freed up for transition. But the very fact that we fought about a transition is just disheartening for purposes of safety with respect to the terror that exists in the world and our enemies, as well as the ability to deal with this incredibly hard, difficult problem. Yes, we are in a difficult recession. I anticipate that we're not going to see it change in the next 7 months. I had viewed it as a cost, as a government enforced shutdown leading to a supply side recession that is now moving into demand side recession. And it is worse than the Great Recession. And I mean, just last month in October, more than 11 million people were looking for jobs, actively looking for jobs, and were unemployed. That's more than twice as many people as the previous October. And at least a third have been doing that for over 27 weeks. So this is a dire time, and we can certainly see it in food banks. And I mean, we've got as a leading indicator of what is happening with respect to access to healthcare. It's hard to really know how that's playing out. It's too soon to know all the numbers, but we can certainly assume that the foreshadowing is seen in the food insecurity that we're witnessing by the demands on food banks. So we need to dramatically, and I just want to speak to now, and I want you to continue to push for demanding that this is a human right and that you should just wake up in the morning, or a child is born today. I have a grandnephew that was just born today, and you know, he doesn't have health. He has health insurance by virtue of his parents' choices, and will have to make choices to have coverage. But as I think others have pointed out, in most of the developed world, you don't think about having to choose. You just have it. And I hope someday we do have it. But the deck is stacked against that, given the fear, the anxiety, obviously the stakeholder interest, and also the corruption in Congress. This is, you know, it scares the heck out of me even to think about a single payer system. Not that I'm not opposed, but I don't trust the Congress to make decisions. You indicated early on about how ensuring that it'd be one system. How do you know it's going to be one system? The Congress is not an expert, and the Congress is subject to decision making that is influenced by stakeholders who lobby on their behalf daily, and they have to be reelected, at least in the House, every 2 years, and every 6 years in the Senate. So there are so many examples, even in this beautiful program that I love to teach about, Medicare, and all the great things that Medicare has done as a social insurance program. But there's many aspects about that which you can see evidence that Congress has failed to do the right thing, and because the stakeholders have a bigger voice. So even in a Medicare for all, we have to be very careful about how we structure the governance of it, because I don't trust the congressional approach to dealing with it. It's clear they don't care. Some don't care, and some don't see it as a right. Clearly, they articulate it's not a human right. So what is needed now? At the moment, we really need to push for extended payroll support so that employers can keep employees. We need to see extended unemployment support. We need to expand temporary cash assistance, as people call TANF. We need to extend food support through SNAP. And I would argue, as a first step, to expand Medicaid, to bribe the states. We're not going to be able to pass legislation for a while, to bribe the states to get on board and at least recognize that they need to protect their citizens. And so I don't want to be too wonky, but I would say we change the income test immediately, so that one looks at the prior 3 months, and that for any families with incomes below 200% of poverty, that they're in the new Medicaid expansion. And I know that not all states have expanded Medicaid. I don't understand that. It's very clear. It's very clear that how divided a country we have, when for 2 years, the federal government offered 100% support to expand Medicaid, and you had states that said, no, I'm passing on that. I don't want to support my citizens. And it then falls to 90%. So it's at 90%. And still you see state after state passing referendum to expand it. The people want it once they understand it, but you have state legislatures that didn't accept it, didn't want to do it. So I suggest we bribe them. We increase the federal match from the current 90% to 101%. And we allow states to use the additional 1% for either expanding their Medicaid or for non-Medicaid social support services. And for those with between 200% and 400% of poverty, we increase the subsidies of the premiums for policies purchased in the ACA exchange. We increase the subsidy for co-payments and deductibles, phasing out at about 300% of poverty. So I suggest that we start by getting Americans familiar with the notion that that healthcare is a right, and we do that by making it easy, and we do that by building on the ACA. And then we start working with a few states so that we don't scare the bejeebies out of the country, and get them to engage in something like Maryland, which is not a single payer, but is an all payer rate setting system, or a single payer system in a section of that state, in a corner of that state, maybe building around the exchanges. And maybe once we have competition among states, and once people realize it's not the end of civilization as we know it, in fact, it might lead to an improved civilization, then maybe we can talk about moving in a second term, assuming there's a two-term Biden administration, then in the second term, they can move towards a single payer system for all. But I don't know how to get over the hump. And I just think about the outrage, the words, the protests, the anger over a very small section of the ACA, which only affected about 5% of the population, but has led to more than 10 years of Congress voting almost daily to repeal the ACA. And still today, we have an administration that went before the Supreme Court 2 weeks ago and argued that the ACA should be repealed. That it is, and the current president, the outgoing president, thinks it is a terrible thing, and there's a lot of people that believe him and I think that's true. So, and I mean, that's over 70 million people that voted for the outgoing administration. So I commend you for pushing the discussion and the arguments. I hope we can come to an understanding that maybe we have to take smaller steps to get there, but maybe through building on the ACA, we can get to a point in which it's an entitlement that everyone is born in America, has a human basic right to care, that we agree that I am my brother's keeper in medical care. And it would be nice to have the kind of problems that even a single payer would have in terms of making sure that there's enough budget and that it's working across systems. And so that someday Medicaid is the same in all states, that some people in this country are not treated differently depending on where you live, in addition to the other reasons that people are treated so differently. So we have a long ways to go, not just on medical care, but also on retirement security and income security writ large. And I certainly think that the pandemic exposes the fissures that have always been there. But I certainly pray that the attitudes and anxiety and the anger that I saw up close with any efforts we've ever taken in the past will dissipate and recognize that we are our brother's keepers in medical care, and that any of us who have coverage today might not have it tomorrow.
Thank you so much, Robert. And thank you to all of our panelists for laying out the situation we're in today and how unsustainable it is. And also, I think we can all agree on what the end goal and what the solution is establishing a single payer system. And so what Robert was saying in his final statements is going to lead us directly into our discussion, which is how do we get there? How do we get to the end goal of a single payer system? What would that look like? What does the organization look like? What kind of activism and what kind of policy will take us to that point? So within the Medicare for All working group, we've come up with a few questions for the panelists. And after we go through some of these, we'll move on to the general audience Q&A. So the first one is inspired by the New York Health Act, which many of you may know has been pushed in New York as a state level single payer system that would create a progressive tax system where you wouldn't require any further money from the federal government. It would just funnel that money in a way to establish a single payer system within the state. So, and in addition to that, Congressman Ro Khanna has also been pushing legislation that would establish state level single payer. So with that in mind, should organizers and activists fighting for single payer focus on adopting state level single payer systems, or are efforts better purposed towards pushing representatives to support national level adoption? And this is open to all of our panelists.
I can jump in maybe first, and I'm sure others have some opinions about this as well. You know, I think that we have been, we're supportive of expanding healthcare, however we can do that. But it is clear, I mean, I do want to just say that we are in a different position politically, I think, than we were even 10 years ago during the ACA debates. We now have a large majority of people in the United States polling, supporting a Medicare for all, or even as when Fox News said, do you support government-run healthcare system? I think they had 74% of respondents say yes, that they did support that. So I think we are in a position where, and then the pandemic obviously has changed the facts on the ground and to an enormous degree. And so I do think we need to recognize that this is a moment where we do need to be working and acting boldly. And I think some states are doing that, and we should be supportive of that. I think that the Biden administration, in their healthcare position, did say that they would support providing waivers to states to be able to enact differences and single payer systems. I mean, currently one of the challenges for states who are trying to do that is actually they would run afoul of federal law in some various ways. There's arguments that they can do it anyway. You know, I mean, I think there are elements to work out there, but we do know that in Canada, for example, their Medicare for all system started at the provincial level and did grow out. So that was how Canada's system came about. So I think we can be supportive. We are supportive of that, though I don't. Public Citizen, at least, does not think that we should do that to the exclusion of really continuing to build a massive movement for federal Medicare for all legislation. Because, and I mean, one of the challenges too at the state level is that it has to be a large enough pool to be able to do it financially. I think we saw in the case of Vermont tried to do that, and it was harder to do at a small state level. And so a New York or a California presumably could do something like that. But again, you know, we really want to be able to, and I think that there is a lot of energy, and we can build the political will to get it done at the national level too. So that would be one initial response.
Yeah, I would just add that, you know, state single payer style reforms are more difficult to do than a national one. They have a lot more challenges. And there's only perhaps a few states where they could do it. But, you know, we have always kind of thought that you can walk on two legs. We've supported viable state reform efforts that have significant labor support. And we think that, you know, particularly in a time when it's unlikely that we're going to have at best a 50-50 split in the Senate and a president who has vowed to veto Medicare for all legislation, we're not going to have a huge national breakthrough. That particularly in a moment like this, that a breakthrough in a couple of states could really help spark and sustain a national campaign. So ultimately it has to be national. You know, and I would also agree with Melinda that I think we're in a much different place than we were 10 years ago in terms of where the prospects for this movement are. I think we have to go bold, and we need to articulate a clear vision to the American people. The trouble with one of the problems with incremental reform is it's so incremental that people often need a calculator to find out whether they're going to benefit or not benefit from it. And that's not the way you build a social movement. In Florida, 49% of Floridians voted for Joe Biden. 61% voted to raise the minimum wage to $15 an hour because it was a bold, clear reform that benefited working people, and people saw that vision and united with it. I think we have to think about the approaches we take in this next period, you know, in terms of breaking through those barriers that prevent us from winning Medicare for all, and not trying to fiddle around the edges of the healthcare system.
If I could jump in real quick, I totally agree with Mark and Melinda here. I think there can be two tracks, and I think especially when we're going into a Biden administration where we may be able to win some healthcare expansion, but likely won't be able to win full single payer over the next 4 years. There's, really great work to be done in certain states at the state level. Certainly National Nurses United has supported both, but to get to a place where healthcare is a human right across this country, where we are guaranteeing the right to healthcare across this country, we need to pursue the federal Medicare for All plan. Like Melinda said, Canada, Saskatchewan went first. There was a massive fight in the province of Saskatchewan. They won in Saskatchewan, and then it started to grow in other parts of the country. And very quickly, actually, the rest of the country transferred provincially to a single payer system. I would just note that, I just want to re-highlight something Melinda said. The Fox News exit poll on election day showed that 74% of Americans, regardless of political party, supported a government-run healthcare system, right? A Medicare for All system, but their language was kind of even more political than what we would say. That is a big number. We are living through a pandemic where tens of millions of people who have relied on their employer-sponsored insurance are losing it, where people are terrified about how they're going to get healthcare in the event they are affected by this pandemic for their children, for their parents, for their spouses. The world is changing right now. And we as a movement, so many of our organizations, including the incredible work of DSA, have been changing the landscape when it comes to healthcare and how we talk about healthcare in the past 5 years. If you think about how people talked about Medicare for All before the Bernie campaign for 2016, think about what it was like then and where we are now. We have a massive movement in every state in this country. The people want Medicare for All, and it is our job as organizers to make sure we continue to build that movement. And so I would just say, I think it is so important that we continue to fight for the real solution that will make sure all patients, regardless of their income, regardless of race or class, get the healthcare we need. We're in a pandemic, for God's sakes, and everybody should have it, and that's not the way it works right now. So I think it's really important we recognize how far we've come and how the political spectrum is changing. And I would just point out that Joe Biden has committed to some improvements, healthcare expansion improvements, that would expand the social insurance model of Medicare. He has said he would expand Medicare to age 60. And I think there is a real possibility with our campaigning work together across this movement to bring him down. Imagine what it would be like if sometime in the next 4 years, we win Medicare expansion to age 50 or 55, or we win Medicare expansion for kids, or we improve Medicare. There are some improvements Joe Biden we may be able to convince him on. That would be a way, those are ways that we could win incremental steps to single payer without hurting the social insurance model of Medicare. We need to be improving the social insurance model of Medicare so that we can get to single payer in a future administration.
Thank you so much. That was a really, really great answer from all of our panelists. So our next question is, what have been the disproportionate impacts of the pandemic on BIPOC communities? And how could single payer rectify this? Are there methods that can help address undocumented migrant healthcare as well within the context of single payer?
Well, I'll start. I mean, I think the impacts have been apparent. You can look at the numbers. Somewhere in the neighborhood of twice as many proportionally people of color have died as a result of the pandemic. The numbers of uninsured and underinsured, are racially skewed. So all of the racial fault lines of our unequal system have been, exposed as a result of this pandemic. Medicare for All is a necessary but not sufficient approach to beginning to resolve those inequalities. It's not a magic wand that can eliminate the scourge of both personal and systemic racism throughout the system, but it is, it does create a universal system with a single standard of care for everybody in this country, and creates healthcare as a fundamental human right, and creates, a public good that's under public control. So it gives us the tools and the structures that can allow us to begin to address the racial disparities and the systemic racism that's built into this system. But we have to make it clear that this is just part of a much broader approach to struggle with the racial disparities and systemic racism.
I think part, if I may, the question in part was also about undocumented people, I believe, right? So it really will depend in so many ways on how generous we are as a people to finance the system. And so this is again why I worry about the congressional part of this. But what we now know is that Medicare is a social insurance program in the context of other payers. What we don't know is how Medicare would operate how institutions would operate in the context without those other payers. And so this will become critical. And which is why I would probably applaud a few states going forward first, because there's a lot of technical aspects to understand about the cost shifting. A lot of medical care right now is shifted around through a variety of mechanisms. So we have overpaying enterprises that are helping to support underpaid and underpaying aspects. And what we see politically is the providers demanding from both state legislatures and Congress to get paid more, in part because of the differential payments. Now, doing away with multiple payers can help that a lot, but the question is, will they have the resources to deal with undocumented workers and undocumented population? Will also depend on the political process by which they get the funding. And so my hope is that they won't have to worry about anything like an insurance card, and therefore, because they'll have the ample funding. But I can certainly imagine that the political process won't write a blank check in that regard. And so if they have global budgets, they're going to worry about who they serve and who they don't serve, I suspect.
I'd like to, I could jump in on that question as well. I think, well, as I mentioned, in terms of the racial health disparities, I mean, it's one, as Mark said, that BIPOC communities are overrepresented and uninsured, but it's not just about coverage. It is also about investments in health care facilities and health care in communities that serve, or in communities that serve those communities, those healthcare facilities. In fact, there was a study, and I'm happy to share it, by a couple of doctors at Harvard recently, that looked at safety net hospitals, or looked at hospitals that served communities of color, higher percentages of communities of color, and saw that there were underinvestments in a whole in facilities, in equipment, and so forth. And so what Medicare for All and the legislation that our organizations have been supporting, as Amir mentioned, the global budgeting has specific elements that would invest more in hospitals based on the need of the community, as opposed to on what the private insurance is able to pay for various things. So it's possible that some of these large for-profit and actually even nonprofit hospitals that have been consolidating around the country, that have really high-end, very expensive units, might lose in the short run over Medicare for all, the safety net hospitals, the hospitals that have been serving communities of need, would very much likely do much better under a Medicare for all system. And so again, that's kind of where you see the equity increasing under a Medicare for all system. And a point on the undocumented, that again, the legislation that we've been supporting, immigrant rights organizations have been very active in working with Representative Jayapal and champions in Congress in drafting language to ensure that this would be all U.S. residents would be protected, people living in the United States, regardless of their documented status. And that's a critical part of any single payer system in our view. And we would, yes, it will be a political fight, but we're there to fight it, to take on that fight.
If I could add one note, which is that many of our various essential workforces in this country are disproportionately people of color, disproportionately Black and brown. And so it really matters when we think about how Black and brown communities have been disproportionately impacted by COVID-19. We have to connect that as well to how we are failing to protect essential workers.
Great. Thank you all for your responses. And with that, we'll move over to the audience Q&A, and we have a few questions already queued up. The first is from Keisha Shepard. Whose responsibility is it to get PPE to workers?
I'll take that one first. Well, it's the employer's responsibility to start with. So the Occupational Safety and Health Administration, OSHA, requires that employers protect workers from workplace hazards that can cause injury or illness, which means it is the responsibility of employers to be protecting their workers. One of the problems we have is that we do not have a federal OSHA standard to protect workers against infectious diseases. We don't have it. Unions have been fighting for it for years. Since the beginning of the pandemic, a lot of you on this webinar may have seen calls from our union and other unions across the country for an emergency temporary standard from OSHA. If we had a real OSHA standard on COVID-19 or on infectious diseases, it would be easier to enforce the protections that nurses and other frontline workers need to stay safe. But I would also just note, while it is the employer's responsibility to protect workers, that the federal government, specifically the Office of the President, has the unique authority to ensure that PPE and other critical medical supplies, that production of PPE and other critical medical supplies is increased. And unfortunately, the current president of the United States has failed miserably to do that. And so we have two problems. We have a problem where hospital employers and other employers in other sectors, other frontline sectors, are not taking on the responsibility as they should be to protect their employees, and that the White House has not stepped up to do what needs to be done. That authority is only one that the President of the United States has to invoke the Defense Production Act to increase the domestic production and therefore supply available to frontline workers for personal protective equipment and critical medical supplies.
That was, yeah, thank you so much. I think it's sometimes it gets very confusing even to know who is actually responsible for this because of how big the echo chamber is. So our next question is from JS, and his question is, can any of the panelists speak to the success and failures of global budget systems in the state of Maryland or the military healthcare system?
I can rattle off some facts about the Maryland global budgeting system real fast, if that's helpful. I don't know that I can speak well to the military system, but I can speak to the Maryland system. So Maryland has been paying all hospitals in the state through global budgets since 2014. And in Maryland, hospital budgeting resulted in $429 million in hospital savings for Medicare within 3 years of implementation. And that outperformed Medicare's initial goal of $330 million in savings over 5 years. And so the Maryland example is seen as being quite successful. I would also just note that the city of Rochester, New York, successfully implemented hospital global budgets in the 1980s for almost a decade under a Medicare waiver. And when that was happening, hospital global budgets led to lower overall healthcare costs for families and a 17% reduction in the hospital component of total healthcare spending. And I would maybe just also add that global budgets have been a really important part of publicly funded healthcare in numerous countries with single payer systems or with other forms of getting to universal healthcare. So global budgets have been used in Canada. They've been used in Scotland. They've been used in Australia. They are being used in Taiwan, the latest country to move over to single payer. So there's a lot of evidence of how global budgets can be used successfully.
Now, I'd like to add to that. I don't know all the empirical evidence on the Maryland's latest round, but I think it's important to understand about Maryland. They have spent a long time really working hard at developing an all-payer rate setting system. So they've spent 30 years with obviously the blessing of Medicare because they need the waiver to not pay the way Medicare pays. And so they've worked, so I would call it, the way to think about it is it's a utility rate regulation model where there's a commission and they review the costs in each section of each hospital. And they negotiate essentially based on the cost information, what the reimbursement will be. And the beautiful part of Maryland is that regardless of your insurance card or whether you have no insurance card at all, the cost of any procedure in that part of the hospital, in that hospital, will be the same, regardless of your payer. So whether you have Medicaid or you're uninsured or whether you have Aetna, it doesn't matter. The cost of that service in that hospital is the same, set by utility rate utility commission. And so it's a beautiful model, but of course it is just the hospital sector. And by going to a global budget, Maryland would like to move to the outpatient sector also. So, but these are long-term efforts that take a lot of effort to learn how to do. And they've been working hard at it, and they've been really successful. Maryland was one of the more expensive states in the union, and now they're in the middle of the pack. And I know the first thing that Johns Hopkins Hospital did when this went into place was they sued the state but nevertheless, they lost the suit, and Johns Hopkins has not lost its luster as being one of the best, healthcare centers, and they've grown in it too. They're actually also an insurance company now too.
Okay, thank you. And our next question is, should there be a world single payer strategy for providing healthcare? Because if one COVID person or COVID positive person travels worldwide, the world is affected.
Well, I think what the virus teaches us most clearly is that we are connected to the rest of the world. And so it's going to be imperative that we support bringing vaccines into the rest of the world for that very point, because we're not safe, even if we can get everyone to get, even if we get 75% of the population here to get vaccinated, and assuming the effectiveness rate is in the 90-95 percentile, we're still going to need the rest of the world to get vaccinated. And so we're going to have to support that. And you can think of it selfishly for yourself, because the virus will, just like the flu, is going to travel around the world. And it's probably going to be every year. So.
And I would add to that, if folks are interested, particularly around the vaccine, some of my colleagues at Public Citizen who are part of a global access to medicines massive global campaign have been working with partners around the globe to demand that any vaccine be global people's vaccine, and that part of the problem with the way that that we grant monopolies to brand name pharmaceutical companies, particularly in the context of a vaccine like this, is not only the cost element, which is that they may price gouge and make billions off of something that should be a public good, but also that they can't produce at scale. Like, we need to be able to make the knowledge available and make it available to manufacturers around the globe to be able to manufacture the vaccine as needed, so that we can, because even Moderna and Pfizer have put out numbers saying we can produce 22 million doses by the end of the year. That sounds like a lot. That's nothing. That's a drop in the bucket, and I think they're talking about, maybe upwards of 500 million. It sounds like a lot, but that's not remotely at the scale that we need globally to make this available. And so we really need, this is the time to be thinking in a really different way about how we think about the medicines and vaccines and healthcare. So I agree. I mean, I don't have a clear answer on how you do global Medicare for all, given the way that governments function in the world. But one thing that we know is that other countries are all doing it way better than we are. So we would do a great service to the rest of the world if we would get ourselves under control here in the United States, for sure.
The lack of leadership at the federal level for dealing with this virus has been, will be written about for a long time. It's just outstanding. It's just remarkable. Basic public health 101 procedures were not followed. But I want to say the untold story, which I think is remarkable, is the way in which scientists globally have interacted with this. They are all opening their labs. They've been working on this from day one. And so many of the things that we're hearing about in the United States that are being developed are also being developed in other parts of the world. Not just other vaccines, but American vaccination or companies that are talking about getting it FDA approved here are also building manufacturers. And we have this wonderful person who was a billionaire, Bill Gates, has built 6 factories, and those are already being produced. They're producing vaccines that haven't been yet approved, so that they can shoot the vaccine in the arms of everyone in the world. So what we're hearing about in the United States is a fraction of what's being done, even by the same companies we're talking about. So Pfizer, for example, has manufacturing plants all over the world that are developing, and they do plan on distributing it, and J&J and all the others that are doing it. I think there's about 6 that are in contention for being available within 6 weeks to 10 weeks. That sound like they'll be available somewhere in the world.
I do think still, though, that even with all of those, I'm not the expert on it on our team, but I'd be happy to share that with others, that even with all of that, we're not talking about the billions of doses that we actually need. So we still have a lot further to go in terms of getting up to scale.
Oh, absolutely. It's going to take till next fall to get everyone in the United States vaccinated. That's correct. You're correct.
I would just maybe add to that what we have seen, unfortunately, is developed countries, rich countries, putting in a massive share, orders that amount to a massive share, disproportionate share of the doses of the vaccine that will be immediately available. And so there is a lot of concern globally about how we ensure that we get, when we have a safe and effective vaccine, when we have that, how we ensure that it is distributed equitably across the world, so that we don't have a situation where rich countries, developed countries are buying up the majority of the doses of the available doses of the vaccine, whilst low-income countries, many countries in the global south, don't have access. So there is a lot of really important and good campaigning work happening, public citizens involved, MSF, others, to try to work with the World Trade Organization, so that there are waivers to existing patent law, so that generic drug companies in places like India and South Africa will be able to produce a vaccine or any other treatment when it's available, when we know it's safe and effective, for easier distribution at a lower cost to low-income countries.
That's remarkable. And I think I would really like to follow up about the Global Access Project from Public Citizen for the vaccine campaign, because I think that's a very, very essential part to controlling this pandemic for sure. And I think our working group would also like to work with you all a little bit more on that too. So our next question is actually for Robert. What do you think about Medicare Advantage for all, or programs like Managed Medicaid? And this is coming from Jay.
You know, it's hard to generalize in these sense. As a whole, Medicare Advantage has cost us more money than it should. As a whole, they haven't saved money for Medicare, in part because they're building off of the risk pooling that Medicare is doing. And so we as taxpayers, or the system pays for that, and Medicare Advantage plans can selectively attract the healthier. And unfortunately, the saddest part is they can encourage the unhealthy to leave. You know, you're free to leave your Medicare. Used to be you could leave anytime, but and join anytime, but the rules did change. You can only leave once during the year. But you know, if your doctor says, you know, I'm sorry you've been diagnosed with cancer, but you know, the best oncologists are not in our plan. That's going to encourage you to leave, and then therefore those expenses will be picked up on Medicare. And so I think we have to, I don't know what the genesis of the question is, but unfortunately, the Medicare system is so gameable that we have had selective risk contracting situations where Medicare Advantage plans are costing us more money because they're getting the low risk and discouraging the high risk, and dumping, if you will, the high risk. I say that, but I want to be clear that when you look at one hospital today, or you look at one managed care plan, you're looking at one. Corporate cultures are so different. It's not really a function of tax status. Corporate cultures are so different in every institution. I really wish I understood enough of how to do that. I like to imagine that we could just, you know, move the water cooler from one system to another, and that the culture in the new system would look like the culture in the other system. We have some of the best places in the world, and yet we have places that are just awful. And it has to do with things that I don't understand. They all have the same equipment. They have the people trained the same way. It's something in the air, something in the ethos. It's not what's on their mug. It's not on their tagline. It's not their mission statement, because they all have the similar mission statements. There's something embodied in some institutions where the people that work there bring about a team effort that brings about better healthcare. And so unfortunately, we have all kinds of apples in the managed care arena. Medicare Advantage arena. So in theory, if you're willing to give up your freedom of choice, then if the system cares about you and really embraces what used to be the old way we used to have group health associations, more of a cooperative, then it's a great opportunity to get great health care. Unfortunately, they're not all the same. And that is proven by the numbers, where you have Medicare Advantage plans that save money compared to Medicare, and those that don't. And the ones that save money, the question is why? Are they delivering care better? Are they more efficient? Are they focusing on preventative care in a wholesome way? Are they thinking about the whole person? Or are they discouraging certain people and to join and encouraging people to leave?
I just got to say that, you know, Medicare Advantage follows the classic neoliberal model of recommodifying public goods. And the way you do it is you underfund the public good, and then you create incentives for private market-based products to siphon off the most profitable segments of that market, and then you you ghettoize the least advantaged in the public system, and then you further underfund the public system. And this is a model that we've seen time and again over the last several decades. Medicare Advantage is a existential threat to the social insurance vision. We need to strengthen Medicare. We need to improve Medicare. It's been, hobbled by, budget limitations and, an antiquated vision of what healthcare is all about from 1965 to the current. And, we need to avoid trying to assert market-based solutions into the system, because that just drives inequality, drives cost, and creates further fragmentation in the system. And in many ways, the public option functions in very similar ways to the Medicare Advantage program would function. That you're commodifying, you're treating a public good now, public healthcare, as if it was a insurance product available for purchase in a private market, and it degrades the notion of public goods. So there's good and bad options in Medicare if you choose it. I mean, a trade union friend of mine who has spent decades fighting against privatization told me she signed up for Medicare Advantage because she got free gym membership and she really wanted to go to the gym. And so you make these private choices, but you need to design a healthcare system that benefits everybody and has a single standard of care for all.
The gym is a perfect example of trying to cream skim.
Exactly. So that only healthy people want to go to the gym, so they're the ones who join the private system.
And the irony of that point is that you and I, as taxpayers, paid for that gym.
Exactly. Well, unfortunately with that, we're going to have to wrap up because we're coming up after the 8:30 mark. But I do want to thank our panelists for their incredible expertise and insight into our path forward out of this mess and towards a single payer plan. I do want to note that on the idea of how to organize and how to fight for this going forward, DSA National is having an event on December 8th for a new national Medicare for All campaign kickoff. So I'm going to link that in the chat for anybody who wishes to attend. I think it'll be a great opportunity to find out how you can get involved and how you can get signed up for some of these actions. And in addition to that, our group is meeting every single Sunday at 5 p.m. For our organizing meetings to find out how to push for single payer. So I'm going to link the meetup for that as well. And again, I want to thank the panelists for their time, thank the audience for their interest and their questions, and hope to be doing this with you all again very soon. Thank you.
Thank you so much.
Thank you so much, everyone. This is Chip Gibbons, he, him, his pronouns. I organized the night school with David. We have a couple of other announcements. I'm going to read them out, and David's going to put the links to the things I'm talking about in the chat since his internet was being glitchy. The first is that on Wednesday, there's a new member orientation, and David's going to put the Action Network link in the chat. Also, there's going to be a DSA Green New Deal plus Medicare for All actions taking place the week of December the 12th. And we will be planning future night schools. We're working to try to do something right now about current events in Latin America, but we're having a bit of a more difficulty than we thought getting that off the ground, but there'll be future night schools. And I believe that's everything.
Good night, everybody. Thank you.
Thank you.